Based on the Onyx 1-month DAPT program, Medtronic is excited to announce FDA approval of the only drug-eluting stent indicated for high bleeding risk patients with 1-month DAPT labeling. Review supporting data at medtronic.com/Onyx1 program.
I am Valentin Fuster for JACC issue of November the 3rd of 2020. The first original paper is entitled Characterization of Myocardial Injury in Patients with COVID-19. The first and corresponding author is Dr. Gennaro Giustino from the Mount Sinai School of Medicine at the Mount Sinai Medical Center in New York. The last author is Dr. Martin Goldman from the same institution. First of all, the clinical evolution of COVID-19, which can often progress from mild respiratory symptoms to severe lung involvement and multiple organ injury, is an example of disease needing accurate risk stratification for preventing rapid and sustained clinical deterioration. Just in this context, our group at Mount Sinai, and based in 7,000 patients COVID positive, has divided the disease in 4 different stages. In stage 1, the virus does not cross the respiratory system and therefore is not disseminated in blood. This may occur in about 40% of individuals. A significant proportion may be asymptomatic. In stage 2, there is dissemination in the blood. Symptomatology is apparent, and although there is no significant organ damage, the patient may need hospitalization. In stage 3, the hospitalized patient is significantly affected by organ damage. Maybe the lung, maybe the heart, maybe the kidney, and even maybe the brain. It's in this stage that the inflammatory component, particularly with activation of macrophages and the release of cytokines, may play an important role in the development of thrombotic phenomena and even into the progression of the disease, entering into stage 4. The patient is very sick, requiring intensive care and carrying a high mortality. It's about 5 to 10% of the patients COVID positive that reach such a stage. All this being said, a significant proportion of patients presenting with COVID-19 infection requiring hospitalization in stage 2, 3, or 4, but particularly in stage 3 or 4, have biomarker evidence of myocardial injury, which has been shown to be associated with increased risk of in-hospital morbidity and mortality. Such myocardial injury, particularly in hospitalized patients, appear to include cytokine-mediated damage targeting the myocardium, and perhaps less common, injury from microvascular thrombi, so ischemic myocardium, and apparently rather infrequently, a direct viral invasion of the myocardium. The study published today in JACC relates to hospitalized patients in our recently published stages 2, 3, or 4, including 7 hospitals in New York City and in Milan, all with laboratory confirmation of COVID-19. In all these patients, myocardial injury was assessed by any elevation in cardiac troponin at the time of clinical presentation or during the hospitalization. In addition, all patients underwent transthoracic echocardiographic assessment and certainly electrocardiographic evaluation. A total of 305 patients were included with a mean age of 63 years. 67% were male. 3 important observations were made. Observation number 1. In this selected group of patients, myocardial injury was observed in 62% of them. Importantly, comparing this group with myocardial injury with the group without myocardial injury, they had more electrocardiographic abnormalities higher inflammatory biomarkers, and increased prevalence of mecha-echocardiographic abnormalities. Observation number 2. In addressing the mecha-echocardiographic abnormalities, we are talking about segmental left ventricular wall motion abnormalities, global left ventricular motion abnormalities, right ventricular dysfunction, left ventricular diastolic dysfunction, and pericardial effusions. And here's observation number 3. Is about the rates of in-hospital mortality. It was low, 5%, in those cases that did not have myocardial injury. Such mortality was intermediate at 18% in those who had myocardial injury, but without echocardiographic abnormalities. And the rate of mortality was high, about 32%, in those who had both injury and echocardiographic abnormalities. So in conclusion, among patients with COVID-19 who underwent transthoracic echocardiography, cardiac structural abnormalities were present in nearly 2/3 of patients with myocardial injury. Myocardial injury was associated with increase in hospital mortality, particularly if echocardiographic abnormalities were present. Dr. Carl Labby from the John Ochsner Heart and Vascular Institute in New Orleans, Dr. Fabian Sanchez Gomar from the Department of Physiology, Faculty of Medicine at the University of Valencia in Spain, and Dr. Giuseppe Lippi from the section of Clinical Biochemistry at the University of Verona in Italy, wrote the editorial comment. The first part of the editorial comment is a well-written introduction to the issue that is discussed, introduction that we already summarized previously. In addressing the paper and the future, 5 comments are pertinent to be discussed. First, and we didn't mention, the body mass index was higher in the group of patients with myocardial injury than in those without myocardial injury. 29 kilograms per square meter versus 26 kilograms per square meter. According to the editorial comment, this is a substantial aspect because obese patients tend to experience worse outcomes and more critical illness in COVID-19. Certainly, this is important, taking into account that 75% of the US population is either overweight or obese. The second comment is about limitations of the study. Certainly, with a relatively small number of patients, 305, and most importantly, a selection bias. This because in all patients, damage of the myocardium or injury was assessed, as well as echocardiographic parameters. So maybe sicker patients. And this leads to the third comment, a very important one. The current recommendations of the American College of Cardiology endorse the measurement of troponin levels when a diagnosis of acute myocardial infarction is being considered in patients with COVID-19 positive. However, based on the paper published today in JACC, COVID-19 patients may benefit from routine transthoracic echocardiography, since the management of such patients may be different depending on the abnormalities found. Certainly, diffuse left ventricular dysfunction, pericardial effusion, or myocardial infarction, or ischemic cardiomyopathy may be approached differently from the therapeutic point of view. Accordingly, Dr. Labby, Dr. Sanchez Gomar, and Dr. Lippi advocate for the measurement of troponin levels in patients that are COVID positive. This done without distinction. And here is the fourth comment. It's about echocardiography. Certainly, as presented in this paper, the most important prediction of mortality is myocardial injury, being worse when echocardiographic parameters are abnormal. So let's assume that addressing injury and we obtain normal troponin levels, and particularly with normal values of other inflammatory markers such as C-reactive protein and ferritin, or of cardiac dysfunction such as natriuretic peptides, all being negative, may safely reduce the need to perform routine tests such as transthoracic echocardiography and stress testing. Furthermore, if echocardiography becomes necessary, there is a potential for the handheld ultrasound as a potential fast, efficient, and cost-effective. And here is the final comment of this excellent editorial. It's about sports, particularly professional sports. And here's the reality. The professional sports leagues are currently performing routine transthoracic echocardiography in all their players who have recovered from COVID-19 and now have positive antibodies. Comment that leads to the last statement of this editorial, and I quote, "Long-term follow-up of patients who have recovered from COVID-19 will be required to further influence routine clinical practices." Close quotes. And this is the message that I carry home. I am proud that our group at Mount Sinai and in Italy have been able to put together such important concept. The interaction of myocardial injury and echocardiographic abnormalities as predictors of mortality in patients with COVID-19. I believe an important statement. Thank you.